advanced breast cancer, as my doctor has rightly said, that most of the times people used to embark upon neoadjuvant chemotherapy followed by mastectomy. So whether it holds good still or not, let us discuss it out in short 10 minutes time. So before we start, let us have a quick revision of the anatomy. The breast, as you know, it's a modified sweat gland and contained between the superficial and deep fascia. It contains stoma, parenchyma, fat, ligaments, and the functional unit is tidlu, that is a terminal ductal lobular unit, nipple eruder complex, axillary vein, and lymph nodes. Arterial supply, it's very important to understand the arterial supply, because nowadays the most of the treatment which surgery is encompassing is deviating from breast conserving therapy towards oncoplastic restoration therapy. So the restoration part, it's very important to understand the arterial supply, from where it originates, and the perforating arteries which supplies the part of the nipple, which different quadrants of the breast per se. So it's important to understand this anatomy of the axilla as well. On the medial side you have pectoralis major and minor, on the lateral side you have latissimus dorsi, and on the superior side the vascular pedicles. As you know, if I'm not mistaken, most of us are acquainted with these photographs. William Halsted. I think William Halsted is known to everybody. Ma'am? Yeah. So William Halsted was the one who invented radical mastectomy. So radical mastectomy nowadays nobody practices. Then came Bernard Fisher. He started sampling the axillary dissection and the surgery was reduced. Then came Almadiano, and he revolutionized the entire system by introducing sentinel lymph node biopsy. Now, what are the challenges which we face in our day-to-day practice? Dr. Niharika, would you like to highlight what are the challenges any surgeon faces while encountering locally advanced breast cancer? The baton has been passed from a medical oncologist, or you directly get a patient. Now, what are the challenges you are facing?
Sir, the patients we are getting, generally they are in, the tumor size is between 3 to 5 centimeters. We have given it to the medical oncologist, they have reduced the size to 2.5, we have put the fiducial marker. And then after that, the things that should be kept in mind, whether BCS is possible in this or not. And sentinel lymph node biopsy is the upcoming point of discussion post NCT. So in that case, if the patient was upfront, it was clinically node negative. Before giving the chemotherapy, it was clinical node negative and the tumor size was 3 centimeter or 4 centimeter. It has come up to 2 centimeter. And now it has come out that the sentinel lymph node can be done as false negative rate are less than 10%. And the thing is that it is more or less equal to the upfront.
So what are the problems you are facing? Basically I want to focus on